but at least you should know the material, how it is used, when it is used, and when it is not used. That's it. So Finn defined pulpotomy as complete removal of coronal portion of the dental pulp, followed by placement of suitable dressing and medicament that will promote healing and preserve vitality of the tooth. So main rationale is preserving vitality of the radicular pulp in doing a pulpotomy. AAPD defined American Academy of Pediatric Dentistry defined pulpotomy as amputation of affected, infected coronal portion of dental pulp, preserving the vitality and function of remaining part of radicular pulp. Objectives: removal of infected and inflamed pulp, preserving the vitality of radicular pulp and allowing it to heal. That is the main objective of pulpotomy. That will remove whatever the infection is, and the healthy tissue will unnecessary will not remove and maintain it in the healthy state in the tooth as it is. The radicular pulp is healthy and capable of healing after surgical amputation of the affected or infected pulp, maintains the tooth in physiologic condition. Indications will be tooth showing a large deep carious lesion but free of radicular pulpitis. Now, how will you come to know whether the tooth has only pulpitis in coronal portion, whether the radicular portion is inflamed already or not? Is first of all based on the symptoms. If the patient gives history of night pain, spontaneous pain, you already know that the inflammation has reached radicular pulp. If the patient does not give history like that, then you can still think that the radicular pulp may be vital and healthy. So in those cases where the inflammation is limited only up to coronal portion, then you can go ahead with pulpotomy. And how you will decide is by both ways. First, based on the history, and second, intraoperative. That will be operative diagnosis. When you are already opened the chamber, then you examine and then you see how the hemorrhage is and then you decide. So pulpectomy is seldom a pre-planned procedure. Okay, pulpectomy is most commonly done as operative diagnostic procedure. You have already started the procedure, you feel that the radicular pulp is healthy, so you stop at coronal pulp. Clinically, from clinical perspective I am speaking, that it is seldom a pre-planned procedure. Carious pulp exposure is encountered in primary teeth. Then if carious pulpal exposure is there, then you definitely know that the coronal pulp is definitely going to be inflamed. But based on history, you may think that radicular pulp is slightly is still not inflamed. Then you will do a pulpotomy. Hemorrhage from exposure site is bright. This is very important. Now you have removed the coronal pulp, and the hemorrhage is bright red and it can be controlled. Now there are various studies in how many minutes the bleeding should be controlled, and the most accepted view is within 5 minutes after slight pressure applied with moist cotton pleasure. It should be, the bleeding should stop. If it does not stop even after applying cotton for 5 minutes, there is still oozing, that means the radicular pulp is also inflamed. Right? And then you go ahead with more invasive pulpectomy procedure. History of pain should indicate healthy pulp. जिसके पास वॉच है ना, मुझे 7:05 या 7:10 को बता दो तो मैं ये वाइंड अप करके केरी स्टार्ट करती हूँ. वो भी लेना है ना 7:30 को. That's why. Just tell me when it is 7:10. Carious, okay. History of pain should indicate healthy pulp or reversible pulpitis. Like I said, the patient should not give a history of night pain and spontaneous pain. Absence of abscess or fistula. If you can frankly see any abscess or fistula or any draining sinus, you already know that let alone the radicular pulp, it has reached the periapical tissue. So you will definitely not do a pulpotomy. So absence or abscess or fistula should be there, and no interradicular bone loss radiographically. At least 2/3 of the root length is still present to ensure reasonable functional life in young permanent tooth with vital exposed pulp and incompletely formed apices. This is the most common indication because you want to close the apex. Okay, and traumatic pulp exposures. These are all the indications for pulpotomy. Criteria for case selection were given by these authors. Teeth with deep carious lesion, radiographically caries should be closely approximating but not involving the pulp. If it is frankly involving the pulp radiographically, then it is going to be irreversible pulpitis in radicular pulp also. Okay, if there is a frank involvement, then it is not going to be, the radicular pulp is not going to be healthy, because if there is frank involvement, the bacteria have already reached the coronal pulp. So bacterial toxins have reached the radicular pulp, right? So the radiographically the caries should be closely approximating to the pulp, but not frankly involving to the pulp. Tooth should be restorable after completion of the procedure. Absence of symptoms indicating advanced pulpal inflammation such as spontaneous pain or history of night pain. Absence of clinical signs and symptoms. Absence of clinical radiographic signs of pulpal necrosis, furcation involvement, pathologic internal resorption. ये सब नहीं होना चाहिए. Furcation involvement should not be there. Internal resorption should not be there. Calcifications. These are all the signs telling that the inflammation and infection is chronic. When there is resorption, calcification, or furcation involvement, or periapical pathology, you know that the infection is chronic and a long-standing one, and you cannot go ahead with pulpotomy. ठीक है? Hemorrhage from the amputated pulp stump should stop within 5 minutes with the help of sterile cotton pledget or moist cotton. Contraindications: persistent, nocturnal, spontaneous toothache. I have already told. Tenderness on percussion or palpation. Tenderness है मतलब there is periapical spread. Highly viscous, sluggish, excessive hemorrhage from amputated radicular root stumps, pulp stumps I mean, not root stumps, okay? Pulp stumps, which is uncontrollable. Any sign or symptoms of inflammation extending beyond the coronal pulp, that is a contraindication. Root resorption more than 1/3 of root length. The root is going to exfoliate, the tooth is going to exfoliate, so you will not do a pulpotomy. Periapical or interradicular radiolucency, large carious lesion with non-restorable tooth. If the tooth is non-restorable, if you cannot restore it, then there is going to be micro leakage. If there is going to be micro leakage, there is going to be reinfection. So the tooth should be restorable. Medical contraindications like heart disease, immunocompromised patients, like I have already told you, swelling of pulpal origin or fistula, pathologic external and internal root resorption, pathologic mobility, and calcification of pulp. Now the advantage of pulpotomy mainly is you avoid all this bizarre, weird, tortuous root canal system in which pulp extirpation is extremely difficult. Can you see? This is one impression made of the primary root canal system. Can you see how many branching is there, how much branching is there, and interconnected canals, right? And the canal is very narrow. It is ribbon shaped. It is not oval or triangular like in permanent teeth. It is ribbon shaped. So the BMP becomes that much difficult. So unpredictable and tortuous root canal system of primary teeth is avoided. Thin enamel and large pulp. So we bypass all this root canal system and still we save the tooth. So that is one advantage of pulpotomy. And thin enamel and large pulp chambers, matlab, there is high pulp form, large pulp chambers are there. So if you restore the tooth, there are chances of pulpal exposure. So restoration will be too conservative, pulpectomy will be too invasive. So middle procedure is pulpotomy. Radiographs of extracted, unsectioned. This is a study just to show that the pulp forms in the primary teeth are high. I don't think you will need this. You just remember that they are high, and that's why there are more chances of pulpal exposure while cavity preparation. The clinical significance of pulp exposures. The pulp exposures can occur very easily in primary molars. Behavior management and cooperation may be difficult in children for extensive restorative procedures. Reasonable treatment option. To meet all these criteria, pulpotomy becomes the most reasonable treatment option. Classification. A classification you have to remember. Vital pulpotomy, non-vital or mortal pulpotomy. In vital pulpotomy, there are again three types. There are different names. Devitalization is also called as mummification, is also called as cauterization. Preservation is also called as minimal devitalization or non-inductive, and regeneration or inductive or reparative. And in devitalization, there is again single visit and multiple visit. In multiple visit, we use Guy's paste. In single visit, Formocresol, Electrosurgical and laser. Procedure. First, you have to local anesthesia, isolation. I have not included that because it is commonly understood. Okay, you have to give local anesthesia, isolation, caries removal, removal of the pulp chamber. That is complete deroofing you have to do. The canal orifices should be visible. What will happen if you do not do complete deroofing is there will be remnants of pulp tissue behind or below that those dentine pulp tissue tags which will remain below those overhangs of dentine. Are you getting what I'm saying? I don't think I have a diagram for that. See, now you can see that there is straight line access to the root canals. There is complete deroofing done. If the burr was slightly more inside the tooth and the dentine on the lateral part was not removed, then coronal pulp tissue beneath that dentine would not have been removed, right? And that would cause continuous hemorrhage. And you will think that there is continuous hemorrhage, so radicular pulp is not healthy, right? So you have to make sure that you have done complete deroofing. Even if you are not going to do a pulpectomy, you have to make sure that complete deroofing is done. Then removal of coronal pulp with spoon excavator or round burr. Then hemostasis is obtained with sterile cotton pellets. Now most commonly used is Formocresol with 95% success rate. Most commonly used, and it has shown a good long-term success rate. Medicated pellet with either full strength or diluted Formocresol is placed with slight pressure for 5 minutes. Now there are again many controversies regarding for how much time the Formocresol should be kept. The current concept is 4 minutes. Ingalls states that it should be kept for 5 minutes. Some authors state that it should be kept for 1 minute, but the current accepted approach is 4 minutes. But we have in clinical practice also we have done with 1 minute approach and it is equally successful. But I think for academic purpose you can write 4 to 5 minutes, you can mark. Now the Formocresol which we use is either full strength, or what we use in clinical practice is not full strength. We use Buckley's Formocresol. The pulp is assessed for continued bleeding. If bleeding is there, pulpectomy we should do. If bleeding has stopped, you see nice 3 brown spots. In mandibular molars when 3 canals are there, so you see nice 3 brown spots which show that the pulp is fixated. There is no oozing of blood. The chamber looks all clean. Then you put the ZOE. Right? Then placement of ZOE. Then they have not shown in this, but you have to put a GIC or composite restoration and then a stainless steel crown. Clinical signs and symptoms should resolve within about 2 weeks. After this, pulpotomized tooth should remain asymptomatic, exhibiting no pathologic mobility, sensitivity and pain. The Formocresol was introduced by Buckley in 1904 to treat necrotic and putrescent pulps. You just go through all this, you don't have to remember. I think sweet you have to remember because he introduced Formocresol pulpotomy in multiple visit techniques. So they might ask this one name, that first Formocresol pulpotomy was multiple visit and it was introduced by Sweet. Then there was 2 sitting, then 5-minute protocol with partial devitalization, and then 15-second procedure, but it was found to be inefficient. 15 seconds was too short. So current concept is 4 minutes, and according to these authors it is 5 minutes. According to Engel also it is 5 minutes. So you keep in mind both 4 minutes and 5 minutes. Engel and some authors say 5 minutes, some authors say 4 minutes. Buckley's formocresol composition you have to mug up. Cresol 35, water 31, formaldehyde 19, glycerol 15, and 1 part of this with 5 part of glycerin. So that becomes 1/5 concentration of Buckley's formocresol. Mechanism of action. Now how formocresol acts is very important. It bonds to the peptide group of amino acids of proteins. There are proteins in the pulp tissue. They have peptide groups. So formocresol, the aldehyde group will bond with that peptide group and it will fix the pulp tissue. The proteins are also enzymes. The enzymes in the pulp tissue are also proteins. So formaldehyde is bonding with the other pulp protein also, with enzymatic proteins also. So it will end up inhibiting those enzymes. Because those enzymes like collagenase are inhibited, the lysis of pulp tissue will be inhibited and the pulp will remain fixated as it is for the duration of lifespan of tooth. Right? So it will bind to the peptide group of protein and prevent tissue autolysis. Reversible procedure. It is the bond with peptide group is reversible without changing the basic structure of proteins. So it is bactericidal as well as a devitalizing, that is fixating agent. It inactivates the oxidative enzymes in the pulp tissue, inhibits the hyaluronidase enzyme. Hyaluronic acid is a major component of ground substance of pulp, right? So it will prevent the autolysis, inert and resistant to enzymatic breakdown. The pulp tissue will be inert and resistant to enzymatic breakdown. It will remain as it is. सिर्फ कंक्लूजन पढ़ते जाओ. Formocresol procedure should be regarded only as a way to keep primary teeth with exposed pulps for functioning for a short period of time. It should be considered as temporary procedure for primary teeth. Use of medicated pellet prior to the placement of base was unnecessary, but this was again contraindicated. What he said was, you add the formocresol to the ZO, you are applying the ZOE later, right? So in the eugenol only you add that drop of formocresol and you need not apply the formocresol separately, but the success rate was not good with this type of case. And in that you are keeping the formocresol is carcinogenic, mutagenic. You are keeping the formocresol in prolonged contact with the tissue. Here you are keeping it for 4 minutes and removing it and putting a ZOE base. Here you are keeping it for a long duration, so this was not advised. Then adding same. If formocresol was added to the ZOE, then adding highly cytotoxic material to the cement base that remains active for a long time may not be necessary for the successful treatment. Garcia-Goda application showed that application time of 1 minute produced less inflammation than 3 to 5 minutes. So some authors advocate 1 minute procedure also. Formocresol incorporated into the ZOE base produce more intense inflammatory response. The longer formocresol is in contact with the pulp tissue, the worse is the tissue response. Compared ZOE base and polycarboxylate base. I will tell you only the important studies because %20 concentration we have already seen. We are using only the 1/5 concentration. 1/5 is 20% only, right? Yes, now this is important. The zones of, the zones after fixing with formocresol. These were given by Maas and Zimmerman and Maslach-Mansukhani. And first there is zone of fixation, then there is zone of coagulation necrosis, and beneath that is the vital tissue. Okay. Most apical zone is maintained of normal pulp tissue with vital odontoblast. Zone of inflammation, pale acellular zone, fixed eosinophilic zone, and response of pulp tissue appears to be time and concentration dependent. More the concentration, more will be the zone of fixation. More for more time if it is placed, more will be the zone of fixation. So first will be fixed and eosinophilic zone. Beneath that, pale acellular zone, which is that of we just saw in the diagram, coagulation necrosis. Below that, zone of inflammation, which was not shown in the diagram, and below that, vital pulp. You want to see? First is fixation, eosinophilic. Second is pale cellular, which correlates with coagulation necrosis. Then zone of inflammation is not shown here. And apical most, which is written above, is vital pulp. Hmm? Now, after 7 to 14 days, mainly these three zones are seen: fixation, coagulation, necrosis, and vital tissue. You just keep this diagram in mind, that will be enough. Fixation, necrosis, vital. Hmm? Progressive apical movement of these zones without acidophilic, with only acidophilic zone left after the 1 year. After 1 year, no vital tissue will be left. Entire radicular pulp will be fixated. Hmm? Now, disadvantages of using Formocresol: it is cytotoxic in nature, weak allergenic potential, teratogenic and embryo toxicity to chick embryos, and International Association for Research of Cancer has labeled it as carcinogenic to humans. It causes leukemia. Hmm? So only 1/5 concentration should be used for minimal amount of time. Now, glutaraldehyde. Even though Formocresol has those disadvantages, the long-term success rates and more number of studies are for Formocresol only. So till now, most commonly used is still Formocresol. But these are good alternatives which have better fixative properties than Formocresol, but which are slightly expensive, not readily available, so not that commonly used. But we should know them. S. Gravenmade and Danker et al. Have introduced this. Satisfactory fixation with Formocresol required an excessive amount of medication. Formocresol with Formocresol for satisfactory amount of fixation, more amount of Formocresol was required and longer periods of interaction. Therefore, 2% glutaraldehyde can be used as an alternative. The concentration they will ask 2%. 2% cold and buffer. It is less antigenic. Binding to protein tissue is irreversible. In Formocresol, the bond with peptides was reversible. In here, it is irreversible. Forms strong intra and intermolecular protein bonds, leading to superior fixation by cross-linkage. Fixation is superior than that with Formocresol. With cross-linkage, how it acts is mechanism of action: rapid surface fixation of the underlying pulp tissue, narrow zone of eosinophilic tissue which blends into normal vital pulp apically. With time, same zone of fixation and vital pulp apically. With time, glutaraldehyde fixed zone is replaced by macrophagic action with dense collagenous tissue. Then entire canal tissue is vital. With Formocresol, it was different. The entire tissue was becoming fixated. Here it is remaining in vital state.
That is irreversible.
The bond with the protein, the peptide group is irreversible. But the fixation, it is not reversible or irreversible. They are just saying that the fixated tissue will be removed with macrophagic action and it will be replaced by vital tissue. The fixation itself is not reversible. You're getting? It will be replaced with vital tissue, so the canal tissue will be vital as opposed to Formocresol. Glutaraldehyde is absorbed into systemic circulation, but there was low amount of tissue binding and less likely to diffuse out of apical foramen. Okay. Less likely to diffuse out of apical foramen because the molecular size of glutaraldehyde is more larger than that of formocresol. कुछ बोला सर? Molecular size of glutaraldehyde is larger than that of formocresol, so the systemic absorption or the diffusion into the apical foramen is less likely. Effective disinfecting and antimicrobial properties does not reach the nucleus of the cells. Its potential for mutagenicity is low. Causes less necrosis of the pulpal tissue, less mutagenic, low tissue binding, readily metabolized and excreted. So these are all the advantages. Sometimes there is allergenic reaction. Even though it is better fixative agent having two functional aldehyde groups, it cannot replace formocresol. Not readily available, expensive, and less amount of literature review available. For formocresol, there is extensive literature claiming good success rate, proven good success rate. That's why even though glutaraldehyde is better, it has still not replaced formocresol. Review of literature, I don't think should be the need. I will just tell if anything is important among the review. No damage to erupted permanent teeth. That you can correlate with the fact that it is less likely to diffuse out of apical foramen because of larger molecular size. Inadequate fixation leaves deficient barrier to surface irritation, resulting in internal absorption, but that is attributed to the fact that it is inadequately fixed. If it is used in concentration of 2% for right amount of time, then the fixation will be fine. The medicament is not ideal material to replace formocresol. Safety problems and conflicting studies about clinical success rates. Now, so glutaraldehyde you understood? Now ferric sulfate. Ferric sulfate was introduced by Landau and Johnson. They noted the secondary dentin formation and partial dentin bridging. So even though we have included this under vital pulpotomy was of 3 types. Can you tell me the 3 types? Fast. Just now we saw. Devitalization, preservation and regeneration. So ferric sulfate we categorize under preservation, but still these authors have noted slight evidence of secondary dentin formation and partial dentin bridging, promising medicament for teeth indicated for pulpotomies. How we use it is 15% for 10 to 15 seconds. Hemostatic agent it is. The mechanism of action is agglutination of blood proteins will be caused by ferric sulfate, and that's why the pulp will remain vital. In the acidic, it will not allow, because of the layer of agglutinated proteins on the radicular pulp, it will not allow any irritants to pass through that layer, and the radicular pulp will remain vital. So the plug formation will occlude the capillary orifices as well as the canal orifices. Functions solely in passive manner, so it is not binding to any protein or it is not actively changing or fixing pulp. So it is acting totally in passive manner. So if they ask you which is the medicament which acts in passive manner for pulpotomy, is ferric sulfate. Minimal chances of inflammation and internal resorption because it prevents problems associated with clot formation. Metal protein clot at the surface. Metal protein as in metal is ferric, and protein blood protein that agglutinate or clot at the surface of the pulp stump acts as a barrier to the irritating components of the subbase, as I just told you. The concentration 15.5% for 10 to 15 seconds. They'll ask you this. 15.5% for 10 to 15 seconds. After rinsing with distilled water from air water syringe and drying, pulp stumps were covered with calcium hydroxide paste and teeth with definite and then definite restoration. See, these authors are also telling the same thing, that ferric sulfate is not a tissue fixative. It leaves the tissue in more vital state. Thus, using ZOE as subbase introduces irritant. So, these authors have proposed that you should use calcium hydroxide, but again, calcium hydroxide may lead to internal resorption. So, we use ZOE base only with ferric sulfate. Sometimes calcific metamorphosis may be seen, but even if calcifications are seen in the pulp canals, these are not considered as potentially damaging to the underlying successor tooth, and as such are not indicated as treatment failure. Success rate is really good, 90 to 99%. One study has quoted success rate of 100% till 36 months. They have followed up the pulpotomized teeth with ferric sulfate for 3 years, and they have found 100% clinical success rate and 99% radiographic success rate. But after 3 years, they have no data. Until 3 years, 100% success rate. The most important finding is that statistically significant difference in the success rates between ferric sulfate and formocresol existed, with the exception of one short-term study with statistically significant difference was observed in favor of ferric sulfate at 1 year period. Based on these studies, ferric sulfate can be used instead of formocresol for treatment up to 36 months. Now, electrosurgical pulpotomy. All this is again under devitalization. Mack was the first dentist in the US to perform electrosurgical pulpotomy in 1993 with success rate of 99% for primary molars, non-chemical devitalization procedure. Electrocautery carbonizes and heat denatures the pulp and bacterial contamination. What it does is denaturation of pulp proteins, so the pulp will become fixed, and it will remove the bacterial contamination, so it will maintain the pulp in healthy state. No sparking or tearing of tissue indicates the appropriate setting. Now this I have taken only for diagrammatic purpose. This is not a picture of pulpotomy. I just wanted to show how the electrosurgery rod looks or the electrode looks. No sparking or tearing of tissue indicates appropriate setting. The pulp stumps were touched only momentarily by the electrode in a brushing type of stroke. 10 seconds were allowed to elapse before re-administration to decrease the possibility of latent heat accumulation. So you apply the electrode and touch it very lightly and momentarily for a second, remove it, wait for 10 seconds, then reapply it. If you apply it again and again before waiting for 10 seconds, there will be latent heat accumulation. Okay. Advantages: quicker than formocresol pulpotomy. Self-limiting pulp penetration is only few layers deep. As with formocresol, we saw that zone of fixation was going on increasing in size. Here it is self-limiting, only few cell layer deep. Hemostasis is very easily achieved. Good visualization without chemical coagulation and no systemic involvement. Avoids harmful chemicals. Disadvantages: in some cases it causes pathologic root resorption, periapical or furcal pathology. This technique does not eliminate the inflammation within the pulp tissue. See, now if your diagnosis is slightly wrong and the radicular pulp tissue was slightly inflamed, formocresol fixation would have taken care of that. Ferric sulfate or glutaraldehyde fixation would have taken care of that. But electrosurgery penetration is only few cell deep. So if your middle third of radicular pulp was inflamed and your diagnosis was inaccurate, then your process will be a failure. So with electrosurgical pulpotomy, success is reliant upon initial inflammatory status and accurate diagnosis of the inflammatory status of the pulp. 99% success rate. Technique is same till achieving hemostasis. Now till hemostasis, the technique is same. Caries removal, de-roofing, moist cotton pellet, everything. This is the electrocautery unit. Hyfricator is the name. Hyfricator plus 797, 40% power, 12 watts. Just read once. So if any MCQ comes, you remember what was the setting. These are the various types of electrosurgical electrodes. First is 711B. I don't expect you to remember all the names, but at least you should have an idea. 711B is general purpose electrode. 705A is 75-degree needle electrode. Then the next third one is 30-degree angle fine electrode. Then 138004 is desiccation or coagulation 5 by 8 inches needle electrode. See, you can see needle like shape. The length is 5 by 8 used for desiccation and coagulation. And last one is ball electrode. You can easily guess it is the ball electrode for controlled coagulation. Ball electrode, needle electrode, 30-degree needle, 75-degree needle and general purpose. For pulpotomy, we'll use this 75-degree angled, length is half inch, used to deliver the electrical arch. 705A electrode. 705A, 75-degree, half inch. Now there are two modes of usage of this type of electrode. One is electrodesiccation, when you touch the tissue with the electrode, and one is the arc is delivered. The tissue is the electrode is slightly away, 1 mm away from the tissue, and arc is delivered. So what we do in pulpotomy is we touch the electrode momentarily. The cotton pellet is quickly removed. Electrode is placed 1 to 2 mm above the pulp stumps. Now this author had used it by touching the pulp stumps, and now this author has used it keeping it 1 to 2 mm above the pulp stumps. But most of the literature tells that it should be kept above the pulp stump and an electrical arc, like in the latter figure you can see an electrical arc is delivered. Directly we touch for hemostasis and coagulation. If hemostasis is already achieved, then we can keep the electrode slightly above the tissue and deliver the electrical arch. The electrical arc is allowed to bridge the gap between the pulp stump for 1 second, followed by cool down period of 5 seconds. That author had kept the cool down period for 10 seconds. He was touching the tissue directly. So the cool down period was more, 10 seconds. Here it is 5 seconds. I don't think they will ask you MCQs on the cool down period. You just keep in mind it is 5 to 10 seconds. Heat and electrical transfer are minimized. The electrode is touched maximum 3 times. Pulp stump should appear dry and completely blackened. It carbonizes the pulp tissue. So it will appear, with Formocresol you can see brown stumps. With this you will see black stumps. And then zinc oxide base. Histological results after 1 hour. The zones which we saw for Formocresol was fixation, necrosis, vital tissue. For here it will be cellular and nuclear debris, localized coagulation necrosis, then a layer of fibrosis, which was not there in Formocresol, and then normal pulp tissue. Debris, necrosis, fibrosis, normal pulp tissue. Only 1/4 of the canal was affected. After 1 week, zone of necrosis was 2 to cell layer thick, followed by cell-free zone, edema, that is inflammatory zone, and normal pulp tissue extends 4/5 of the canal. After 2 months, necrotic debris and inflammatory response was there, and remaining 2/3 of the tissue was fibrotic pulp. So here mostly we will see fibrosis. In some cases there was secondary dentin deposition, effort by healthy vital pulp to wall off the or heal the area of insult. Now lasers. Earlier studies, there is one MCQ asked, which kind of laser will you use? That is CO2, argon and NDI lasers are successfully used. Most commonly used is NDI. What is the full form? Aluminum carbide. Create superficial zone of coagulation necrosis that remains compatible with the underlying tissue. Advantages are have potential to increase healing, stimulate dentinogenesis, preserve vitality of the dental pulp, bacterial reduction in dental tissues. So it will completely take care of bacterial contamination. That is the major advantage of lasers. better wound healing when exposed to Nd:YAG laser than controls, facilitation of dentin bridge formation 12th week post-operatively. It is used as 20 Hz, and IRM was used as sub base. This again is one study with Nd:YAG laser, 2 Hz, 20 Hz, IRM base. Pulpectomy पूरा बाकी है. This was introduced into canal orifice through standard quartz 320 mm optical fiber. याद रखो optical fiber. 6 months, 1 tooth showed internal resorption. 9 months, half the teeth showed canal calcifications. So as we can see that there is complete obliteration of pulp canals, but clinically the tooth was asymptomatic. So these can be alternatives to Formocresol pulpotomy: Nd:YAG laser, electrocautery laser, then Glutaraldehyde, ferric sulfate. Just see the diagram where the lasing is done with Nd:YAG laser and apply pulp dressing, filling with phosphate cement prior to placement of stainless steel crown. The evaluation of criteria by which treatment was considered successful at follow-up were no pain, either spontaneous or induced pain. There was no pain basically, no pathological mobility, no radiographic evidence of pathology, and apex closure in young. These were the criteria by which they decided whether the pulpotomy was successful or not. Histological characteristics, that is histological response to laser, was necrosis of superficial layer, same as electrocautery, necrosis, then hyperemia and inflammation in inflammatory cells resulting from dentinogenesis, and in some specimens here dentin bridge was observed. In electrocautery, fibrosis. These authors have used CO2 laser, but again most commonly used is still Nd:YAG only. The main advantages of laser assisted pulpotomies are absolutely sterile procedure, no bacterial contamination, formation of thin laser induced necrotic layer which stops the pulp from having direct contact with covering material, avoiding reducing the possible chemical or toxic effects of the material used. The vital tissue underneath will not be in direct contact with the ZOE base that you give, so it will be less irritated. Now 2-stage devitalizer, I will just tell you the materials now. Paraformaldehyde to fix the entire, the procedure is done in 2 stages. In first stage, the materials used are Glycine triopase formula. The formula is tricresol 10 ml, cresol 20 ml, glycerin 4 ml, paraformaldehyde 20 ml, zinc oxide 60 grams. Another material is Islick's paraformaldehyde formula. Paraformaldehyde 1 gram, procaine base 0.03 gram, powdered asbestos 0.05 grams, petroleum jelly 125 grams, carmine to color. Later you just mug up these compositions. Paraform devitalizing paste. Which 3 paste we saw? Glycine triopase, Islick's paraformaldehyde, and Paraform devitalizing paste. Lignocaine 0.06 grams, propylene glycol 0.05 ml, carbovax 1.30 grams, carmine to color. In first appointment only the pulp tissue is removed and formaldehyde gas released from the paraformaldehyde permeates to the coronal and radicular pulp. The cotton pellet with paraformaldehyde is placed at the exposure site and temporary restoration is done and sealed for 1-2 weeks. Second appointment, the restoration is removed and the roof of the pulp chamber is removed, cleaned with saline, hydrogen peroxide. Pulp chamber is then filled with ZOE base like normal pulpotomy. It is just that it is done in 2 appointments if the bleeding is slightly more. CMCP and cresatin can also be used. Partial or swag pulpotomy, mostly done in traumatic exposures. Pulp tissue beneath the exposure is removed up to a depth of 1 to 3 mm as given by swag to reach the deeper healthy pulp tissue, indicated for vital traumatically exposed young permanent teeth. In this way, pulpotomy is done. Can you see the removal of coronal pulp giving calcium hydroxide and ZOE subbase? It was proposed by Mayare and Schweck in 1978 to preserve the vitality of radicular pulp tissue and allow normal root closure. Calcium hydroxide and NT are most commonly used. The arrow shows dentine bridge formation. Can you see? Now, non-vital mortal pulpotomy is Pulpotomy. These were all types of vital pulpotomy. Single sitting, first we saw all the things. 2 sitting, we saw 3 paste, and now this is non-vital. Pulpotomy and Formocresol is used. Ideally, non-vital tooth should be treated with pulpectomy, but it may be impractical due to non-negotiable root canals or with limited patient cooperation. So what we do is on first appointment, removal of necrotic pulp, Pulpotomy dressing, seal for 1 to 2 weeks, and second appointment if asymptomatic restoration. Now regenerative pulpotomy. It is ideal kind of pulpotomy because radicular pulp will remain vital and healthy, and also because of induction of dentine bridge formation, it will be enclosed within a odontoblast lined dentine chamber. Here it was in direct contact with ZOE, or in case of laser, the necrotic tissue, or in case of electrocautery, the carbonized tissue. Now it will be lined by dentine, like it is there in the physiologic state. For regeneration pulpotomy, first material is MTA. MTA was introduced in 1993 as routine filling material, bioactive material. It is a bioactive material. Main components are calcium, silica, and bismuth. I will tell you in short about MTA because now the time is really less. It is mineral trioxide aggregate. When you put it in direct contact with vital tissues, it will dissociate into calcium oxide and calcium hydroxide. Calcium oxide has osteoconductive properties, and calcium hydroxide will again dissociate into 54% will be calcium ions and remaining will be OH minus ions. And OH, what calcium ions will do is activate alkaline phosphatase. What OH minus will do is raise the pH to 12.5, reduce, neutralize if any acidic products of bacterial origin are there, and it will sterilize the site. Now, alkaline phosphatase is already activated. This calcium will mobilize the calcium from bloodstream, and in dentine bridge formation, this calcium will not take any part. The calcium in the dentine, which is newly formed, is entirely from the bloodstream. This also they ask, that the calcium which is there in the dentine bridge is entirely from the bloodstream, not from calcium hydroxide. So it will have osteoinductive property and induce a dentine bridge. It is most biocompatible material because there is no zone of necrosis or fixation. So it is most biocompatible material. It sets in the presence of moisture. There is still a zone of inflammation because calcium hydroxide, when it is produced and dissociates into calcium and hydroxide, there will be some necrosis and some inflammation.